Hi, and welcome to this edition of the Orthopedic Video Lecture Series. This is a summary of a talk on the irreducible hip fracture dislocation. This is a rare event, but it has certain characteristic features that can be spotted if we're willing to look at the pattern. Much like Pearl Harbor, December 7th, 1941, this is a day that doesn't have to live in infamy. At Pearl Harbor, we had radar. We had operators. They recognized it. Joe Lockhart recognized a large wave that he thought was something serious. He conferred with his buddies, and they passed it up to their senior, Lieutenant Kermit Tyler, who was a 28-year-old Navy lieutenant who said, "Don't worry about it." Now, to his defense, he didn't have any training. He was trained as a pilot, and he only had 1 day of orientation at the radar station. So he was later vindicated for not alerting people to the oncoming Japanese invasion. Inexperience and overconfidence can often get you hurt. So our goal here today is to talk about the irreducible hip. What the irreducible hip is not is the posterior wall fracture that's so large that the hip slips back out and requires traction. It's also not the fracture that has irreducible pieces or fragments that keep the hip from being concentric. And we're also not talking about the femoral shaft fracture or other fractures that keep you from being able to place traction and reduce the hip. This talk is really about one article that was written in 2007 by Mehta and Rout, where they recognized this pattern of a femoral head fracture without posterior wall with femoral head dislocation, where in 6 years they found 72 patients with that pattern. Out of those, they had 7 patients, or 9.7%, with an irreducible hip dislocation. That amounts to about 1 to 2 per year, which is typical for what we see here at Vanderbilt. The problem is that the femoral head becomes trapped by the capsule and the labrum so tightly that an attempted reduction might well fracture the femoral neck. In the schematic on the left, the typical dislocation has hip flexion with internal rotation, but this irreducible pattern on the right shows that the patella is straight anterior without much hip flexion and without much rotation. Notice the comparison of the right versus the left foot. I want to show you what the typical hip dislocation looks like. And I'm going to step away and forward this to, this is the typical pattern with internal rotation, hip flexion, and when the surgeon comes to the hip, this is the typical pattern where the hip can be moved around. I'll show that once more. Patient has sedation, the hip is supple, and he proceeds along to the standard traction and hip reduction. So my point is the hip needs to be supple, and this has been noted by one of our residents just recently. So I'll show some case examples, and we'll go through the reducible and the unreducible hips. In this patient, there's a posterior wall fracture with femoral head dislocation, and on CT we can see this. This was the reducible hip. This patient has a femoral head fracture with dislocation and therefore could potentially have irreducible hips, but both hips were supple on exam, as we can see on CT scan. Both femoral heads, and even the femoral heads, closely applied to the back of the acetabulum, but a successful reduction was able to be obtained without femoral neck fracture. This patient had bilateral fracture dislocations with a posterior wall on the right. On the left, there was evidence for a femoral head fracture, and also almost a sense that the femoral head was impaled on the back of the acetabulum. It was a bit deceiving because the right hip reduced nicely and then was held in place with traction. On the left side, a reduction maneuver was performed, and unfortunately, disaster occurred with femoral head fracture concomitant with reduction attempt. Patient had a incarcerated fragment on the right. She went on to receive reconstruction of both hips and later avascular necrosis, collapse, and total hip. So let's go over the features once more. Femoral head fracture, no fracture of the femoral neck or of the posterior wall, and also appreciate the position of the lesser trochanter, which is not typically seen on a typical femoral head or hip dislocation. Because of internal rotation, we don't typically usually see the lesser trochanter. The femoral head becomes trapped, it's not mobile, and reduction attempts can fracture the neck. We can see in this case example of a typical right hip dislocation where we cannot see the lesser trochanter on the right, but it's clearly appreciated on the left. CT scan demonstrates no femoral head fracture or wall fracture, and this was easily reduced. In this large gentleman, he has a femoral head fracture with dislocation. The hip is supple, a reduction attempt performed, and a piece remains in the joint, but no femoral neck fracture occurs. This was a safe bet. This patient had a hip dislocation, and note the absence of the appearance of the lesser trochanter on the left compared to the right, given the patient's flexion and internal rotation, and therefore it's easily reduced by the ED staff. One point of fact, we would like to be contacted prior to ER or trauma staff reduction of the hips, at least to give us a right of first refusal or to provide our expertise if indeed an irreducible dislocation might exist. In this patient, there was a left-sided femoral head fracture with dislocation of the femoral head and close approximation to the acetabulum. A reduction attempt was performed in this 19-year-old and disaster followed with a loud pop and a femoral neck fracture. This was repaired, but unfortunately, patient went on to collapse. You don't want to have a day when that occurs. So again, the schematic on the left side shows you the typical pattern. On the right, the irreducible hip with the patella facing directly towards the ceiling and minimal rotation, minimal hip flexion. This is typically a sagittal plane fracture of the femoral head, as seen in this coronal reconstruction. Note in this patient the simple dislocation, which was easily reduced. So I hope that you've appreciated the features of the irreducible hip. The radar installation on Pearl Harbor is now this type of apparatus, and here at Vanderbilt we've learned to spot the irreducible hip, as noted this year, in this patient who presented with the classic findings. Femoral head fracture without posterior wall. Note the symmetric appearance of the lesser trochanters, which is consistent with her clinical exam with a very fixed, immobile hip despite relaxation. The femoral head fracture closely approximated to the back of an unfractured posterior wall of the acetabulum, seen on this sagittal reconstruction, coronal and now sagittal reconstruction, and then on this 3D, which I'll play for you now. Appreciate the close approximation of the femoral head to the back of the acetabulum. This patient went on to an open reduction, fixation of the femoral head, and satisfactory discharge on post-op day 2. Thank you very much for your time and attention. I hope you've learned something and won't miss the irreducible hip fracture dislocation.